Yeah, so I had heard of I'd heard of you, David. I mean, I remember my colleagues coming back from ASH. I can't remember what year it was, but they were saying they heard the most amazing talk, and it was you giving the talk on Castleman's. But then it didn't really hit home to me until I had a patient who was very, very ill, and really no one knew what was going on, and it was a horrifying situation because the patient was also a colleague, also a physician,
right.
which it hits home doubly hard. And so I still remember there was one day in November when we finally figured out that it probably was Castleman's and it probably was Tafro.
Yep.
But it was my very first case of Tafro, and I didn't know where to turn. But then I thought, well, maybe I should just go on a limb, email Dr. Fajgenbaum and see what happens. And I remember I sent an email with my cell phone number, and I remember I got a call at around 6 or 6:30 p.m. Vancouver time,
right.
which would be like 10 or 10:30 Philadelphia time. And you reached out and you affirmed that, with the information that we provided, that it was probably Castleman's, and that you gave guidance on treatment, and he responded to the treatment. So I just remember that so distinctly, that you would take the time, to call me so late at night because you care so much about, people suffering from this. So.
Well, I so appreciate you sharing that. I do remember that, and yes, I'm so thankful for you. When I tell people about you, Dr. Chen, I say, Luke Chen is the doctor when people have no options. That's who you want to go see, because he's going to figure out a way to treat you. And I don't know exactly how you do it. We have these phone calls, and that was the first of many that we had back in that November. But we'll have these phone calls where you'll tell me about these patients where literally they're on ventilators and life support and dialysis, and everything that should have been tried has been tried. And that's when you sort of are able to somehow pull out these incredible, miraculous sort of treatments that save these patients' lives. And so anytime that I get an email from you, I know that it's going to be an important case to think through, because I know that you don't reach out to me until you've already sort of wrestled. You don't give me the easy cases, right? You sort of handle the easy ones, but you reach out to me when they're really complicated. And amazingly, you've just been able to help so many people. So I'm such a big fan of yours, and just so impressed by everything you've done. So Luke, as I shared, you just sort of stand out to me as someone who, when the patient needs you to come up with something to help them, that you're able to do it. Share with me a little about how you think about helping these people that are in such dire need. Like, how do you think about repurposing one drug or another drug? How do you do this? What's your process?
Yeah, so I was just sharing with Brent earlier. I think there are two important principles. One is being a little bit comfortable with uncertainty, to recognize that we don't always need 100% certainty on the diagnosis, right? If we've done everything that is reasonable, everything that we have access to, I always tell colleagues, like, sometimes, I say, well, this is our good enough working diagnosis, and this is the treatment that we're going to try, and we've weighed out the risks and the benefits, and we think the benefits outweigh the risks. Even though we're not 100% certain, we've got to give it a try. And then sometimes colleagues will be hesitant and say, well, you're not entirely certain, you don't know. I say, well, if you want to be 100% certain, you have to wait for an autopsy in some cases, right? And that's too late, right? Like, I like to help my patients before we get to autopsy.
Exactly, and you do.
Yeah, so I think sometimes you just have to, bite the bullet and go for it. And I think the other principle is, don't let the perfect be the enemy of the good, right? Sometimes, you try something and it doesn't quite work, but I always try to have a plan A, plan B, plan C. Knowing, I think sometimes we limit ourselves, right? We just think one step ahead. So, I'll give you an example. So there's a rare disease called Schnitzler syndrome. It was profiled in the New York Times. It's a very rare condition that's characterized by diffuse skin rash that's very itchy, very uncomfortable, profound bone pain and joint pain, profound fatigue. People who get it, they just cannot function. They'll go from being go, parents of children, working out, healthy, fit people, to just people who can't get out of bed because they're just so fatigued and unwell. And yet, they're critical. They're not going through liver failure or renal failure. Most of their critical organs are okay. And so they'll often grumble along like that for years because doctors don't know what it is. But once you figured it out, once you see that it is this disease called Schnitzler syndrome, most people respond really, really well to anakinra, which is an IL-1 blocker, because it's an inflammatory disease that's mainly mediated by the cytokine called IL-1. Well, I saw a young lady, 24 years old, who had something like Schnitzler's. She got these intermittent urticarial rashes. She had profound bone pain and fatigue and fevers every night and inflammation in her body. But we literally did the $1 million workup, everything, MRI of the whole body, every single blood test under the sun, scans of everything, and we didn't know what it was. But after 3 months of working her up and, trying to figure out what she had, I said to her, you know what, we don't know exactly what you have, but I think it's close enough to Schnitzler's that we should try anakinra.
Yeah.
And I said to her, and you know what, like what I'm proposing is not like intensive chemotherapy. It's very unlikely to make you sick. Let's just try it. And we tried it, and she's 95% better. She's able to, play with her 4-year-old. She's able to, do things with her family. She's able to work again, which she's really happy about. And she's 24 and she has her life back. And we don't know exactly what she has, but does it matter if she's feeling better, right?
No, it doesn't. And even anakinra for Schnitzler syndrome, that's of course an off-label repurposed use in itself, right?
Yes.
And so it's amazing to hear about these examples where a drug like anakinra can be used for Schnitzler syndrome. But to your point, thinking about those things that are sort of tangential or related. I mean, basically, when I think about you, Luke, I think you're like the embodiment of what we're doing with these knowledge graphs with EveryCure. We are looking for drugs that can be used in new ways. And so pick a disease, let's say Castleman disease, and we have this giant knowledge graph with a number of nodes and edges connected to Castleman's. And we find drugs and make predictions around drugs that might be useful for, let's say, Castleman's, for example. What I've seen you do and what we've talked about before is, start digging in, what are some mechanisms of disease that might be relevant to one patient, like the one you just described? What's a disease similar to what we're seeing here? Is there a drug for that similar disease that could work for this disease? And it's really about making these connections. And so I think that what we're trying to do with EveryCure really is trying to recreate the master clinician like yourself that's able to look for these similarities, these mechanistic underpinnings of disease, similar to other diseases, similarities between drugs that can then lead us to trying a treatment. What message would you have for other clinicians around sort of how they may want to think about drug repurposing or hem-onc is obviously a space where there is a lot of trying things off-label. There's other disease states where drugs are not used as much off-label. Sort of any guidance or thoughts you'd share with clinicians who maybe aren't as used to off-label treatment or repurposing drugs?
I think, when we use immunomodulatory drugs for more common diseases, I think we should really pay attention to the side effect profile. And when we see that there are drugs that are effective and generally well tolerated for one condition, to me, those are the big ones that we want to try for the rare diseases, right? Point. Like I think, for example, in the realm of the histiocyte disorders, there's a rare histiocyte disorder called Rosai-Dorfman-Day-Tune disease, and it's a really difficult disease. One, because it's very hard to diagnose. It's often the biopsies, these characteristic histiocytes are often hidden in an inflammatory milieu, and you really need an expert pathologist to see those cells and put it together. And then it's doubly frustrating because sometimes it takes a lot of cognitive effort to get to the diagnosis. But once you've made the diagnosis, there's not a 100% clear-cut treatment algorithm. We are, in the past few years, Dr. Eli Diamond in New York has done a lot of work on targeted therapies, MEK inhibitors of specific therapies that target mutations that are commonly found in this disease. And yet, still about half of the patients are wild type. They don't have a known mutation. And even the ones who do respond to the targeted therapies, those targeted therapies are not easy to take. They cause a lot of skin toxicities, Dupuytren's contractures, quality of life issues, sexual dysfunction, things like that. So they're not easy medications to be on. So you can imagine that you're, someone who's 45 years old, diagnosed with Rosai-Dorfman, and you're on a medication, it works, but it's hard for you to take. It's really impacting quality of life. It's something, but it's not perfect. On the flip side, though, we do know that it's a disease of immune dysregulation, and there are certain treatments that we use for other diseases that can be useful in a subset of patients. So I treat a lot of myeloma, and a commonly used medication in myeloma is lenalidomide, which is now generic, so the cost of it has gone down considerably. And there are a lot of common pathways in myeloma that apply to Rosai-Dorfman-Day-Toom disease. There are a lot of shared pathways that produce abnormalities in serum protein electrophoresis. And it turns out that lenalidomide is very well tolerated, reasonably well tolerated. It's not side effect free, but it's better tolerated, and it works very well in a subset of patients. So it's not the solution for everyone. But you can take it and you can apply it. They never developed that medication just for a histiocyte disorder. But I use it in myeloma. I know it works well in myeloma. I can try it for a month or two. If it doesn't work, we will move on to something else. But it gives us another option.
So Luke, recently I've been trying to think through sort of a mental model or framework around what are all of the things that a clinician like yourself is going to consider when trying to make a decision around using a drug off-label, or maybe it's the first time it's ever been used for a disease, or maybe it's something that's been used before. And I've come up with some categories. I'd love to sort of hear your thoughts on them. So I think when you've got a patient in front of you, I think that the things that come to mind for me are how severe is this disease? That's gonna weigh in whether I'm ready to try something new. I think you're going to want to know the mechanism of the drug, and is there some sort of plausible connection? Certainly. Is there clinical data that suggests, has it been given before to someone? Is there a reason to believe that it might actually help this patient in front of me? I think the cost of the drug comes into play. If it's exorbitantly expensive, that might change your math. I think that how severe that patient is right now, not just how deadly is the disease generally, I think that factors in, but also where is the patient right now in their disease course? And I had a couple other thoughts, which are not coming to mind right now. But sort of, are there others that come to mind for you that as you're weighing these decisions?
I think those are really great categories. I mean, when we think about evidence-based medicine as it is in 2024, we're set up really well to definitively answer very narrow questions. Most randomized controlled trials, the internal validity, if you look at any RCT published in New England or JAMA or whatever, the internal validity is very good. They've had all their statisticians, they've had all their data monitors, and that if a patient looks like a patient that went into that study, they will probably get the same benefit and same degree of benefit as you see in the clinical trial. But the external validity is a whole different ballgame, right? People, ladies are pregnant. People have comorbidities. People have other issues where they may not have been eligible for that trial. And then secondly, I think one of the things you point out is really important. How severe is this patient? How severe is the disease in general? A lot of clinical trials don't take into account the great heterogeneity of disease, right? Like people call you all the time saying, I think this is Castleman's, but this patient's too sick for Castleman's. There's no such thing. It's just a general misconception, right? Or Rosai-Dorfman-Day-Toom disease or IgG4-related disease. There are diseases where there's not a one-size-fits-all model to the treatment, and I think we have to think outside the box, and we have to pick and choose medications with a plausible mechanism of action. And I say plausible because when I used thalidomide and lenalidomide earlier as an example, when thalidomide and lenalidomide were first used in oncology indications or tested, the thinking was totally wrong. They thought, thalidomide was banned because it has anti-angiogenic properties, and so when it was used for morning sickness, babies were born with, without limbs or that sort of thing, and so they thought, well, tumors need angiogenesis, tumors need blood vessels, so let's use it in that. And so when it worked in myeloma, they thought, myeloma is a blood disease. It doesn't really need blood vessels, so what does that work? And then people started coming up with these models of angiogenesis in the bone marrow. That's not exactly how it works. It works in a totally different way that nobody knew about. But the important thing is that it worked. Right? If it works, let's sort out the rest later. Right? But if we have a plausible mechanism of action, that helps, right? And then we can explore it later.
And then that also brings up, so one other category I was thinking about came to mind, and that's safety, right? And so, if you know that the drug is likely to work, has a plausible mechanism of action, you think you can get it to the patient based on the cost of the drug, you want to make sure that it's going to be on the safer side. And certainly, the distinction about how safe is it is also going to depend on how sick is the patient. And so, if there's someone who's in the ICU, you might be willing to take on more toxicity. And as I've been thinking about this mental model around what are the inputs for deciding, do I want to prescribe say, sirolimus for Castleman's or baricitinib for Castleman's or HLH. There's a number of inputs. And then I think another thing that's important to consider is that, let's say each of those categories we described has some amount of points assigned to it.
Yes.
There's going to be a threshold for what that family is going to need to have to say, I want to take it. There's going to be a threshold for what that doctor is going to have for saying they want to prescribe it. So, sometimes patients and families will have a very low threshold where they're like, give me anything, depending on what the disease is like. And sometimes doctors have a lower or a higher threshold depending on what their experiences are. You've certainly been a master clinician to be able to repurpose drugs and save patients' lives. So I suspect you, as you think about the next patient in front of you, say, well, I've had this success in the past. I think I'm ready to take this step again moving forward. And so anyway, that's sort of how I've been thinking about it. I don't know if do you think that's the kind of a useful thing that would be helpful to share externally, or what are your thoughts on just sort of creating some frameworks around how do we make these decisions in sort of a data-free space?
Yes. I mean, I think the issue is transferability, right? I think if you talk to any good doctor out there, she or he will have some story of some time when they went outside the box that they didn't think it would work, and it worked. And then, maybe they never reproduced that, but maybe there's a lesson in there that we can transfer to other patients and other doctors in other situations. And to me, it would be lovely to have a sort of central model where we can plug in all the data points. I think that's a very, it's an ambitious goal, and we should always go for ambitious goals. But to me, really the central lesson is transferability. If someone finds something that really works for a patient in a particular setting, can we transfer that to a different setting, another patient, another setting? Can we keep doing that? Can we keep amplifying that till we find out the underlying principle that allowed that to happen? There's a scene in Indiana Jones and the Last Crusade, right, where Indiana comes to this huge canyon, and there seems to be no way across to the other side, and he has to take a leap of faith. And he just steps out, and boom, he doesn't fall into the canyon. He steps onto a bridge, an invisible bridge, and then when he gets across, he throws some sand across so that his colleagues or his teammates who are coming along can see the bridge, right? And I think that's a lot like what it is with rare diseases. I think when we have a success and we report it, whether it's just a case report or a letter somewhere, and we try and figure out why did that work? And is there a lesson that can be applied to other people? It's like throwing that sand across the bridge. It's like saying, okay, we crossed that bridge, but how many more people can cross this bridge, right?
I love that. I love that concept. It's something that clinicians can do, something that you're doing. We've co-authored papers like that in the past. And something that every cure wants to do, I think, to use that analogy, would be, once we've, put some stand or over the bridge so others can see it, every cure wants to capture all of those bridges and put them in one central place. So that way the next doctor can actually find that bridge more easily and not have to search the world and the world's knowledge to find it. So I think that there's just so much overlap, and I'm so glad to have you here in Philadelphia at Penn. I know you've got a few talks today that I'm excited about. And we're just so thankful for you to be an advisory board member to Every Cure, a close friend and colleague of the CECN. So thanks so much, Luke, for everything you do. Excited for the rest of the day.
It's an honor to be here, and it's great to be involved with Every Cure and CDCNs.